Hi, everyone, and welcome to another episode of the Academics Anonymous podcast. My name is Miguel, and today we are going to be talking about another hurdle in healthcare, and that's going to be the hurdles in healthcare for incarcerated people. So, before we start this episode, I want to clarify that I'm not a legal or medical expert, and I may make mistakes with some of the information that I tell you all today. So, I'm going to try my absolute best to use the article's information, and I'll identify those articles down in the description of this episode so you all can reference them on your own as well. So, we're going to be using a lot of legal precedents and legislation in this episode to describe the state of the prison healthcare system. And that's going to be a very complicated issue that has both legal and medical components to it. So we are going to start off by describing some of the legal precedents as well as legislation that have protected incarcerated populations from receiving the kind of medical care that they need, and those that actually prevent them from receiving proper medical care in some instances. So that's going to be very important. Just to define a term that we're going to be using, the term incarcerated is used to describe a person who is detained in a carceral facility, either before or after trial. So I'm going to go ahead and first list out some of the legal protections as well as court rulings that give and protect some of our prisoners' rights. And the first one's going to be the Eighth Amendment in the Constitution. The second one is the Estelle v. Gamble ruling in 1976. Then Farmer v. Brennan in 1994, Helling versus McKinley in 1993, and Americans with Disabilities Act published a passage in 1990 that also protected the rights of prisoners. Then there was a act that was put in place in 1996 called the Prison Litigation Reform Act, and I'm going to describe that as well in just a second. So with the emphasis that this episode is going to have on the legal component of this issue, I'm going to dedicate the first part to describing what these legal legislation, these legal precedents and laws are. Then we're going to talk about the medical component, and then we're going to be looking at one article in particular, and that article's solution to healthcare in carceral settings. The article that we're going to be looking at to describe all of the legal precedents as well as the laws is going to be the Healthcare in U.S. Correctional Facilities, a Limited and Threatened Constitutional Right. And this was published in the New England Journal of Medicine. And this article was really helpful for me. It was able to describe a lot of the information in a very digestible manner. So if you all are interested, you can check out this article in the description of this episode. And I'm going to describe for you what they said in their article. So to start, the Eighth Amendment. This states excessive bail shall not be required, nor excessive fines imposed, nor cruel and unusual punishments inflicted. And the next up here is Estelle v. Gamble. This is 1976. So the Supreme Court ruling held in Estelle v. Gamble that correctional facilities have a duty to provide limited healthcare services, holding that deliberate indifference to an incarcerated person's serious injury or illness constitutes cruel and unusual punishment prohibited by the Eighth Amendment of the Constitution. Then Farmer v. Brennan. In 1994, in Farmer v. Brennan, the U.S. Supreme Court further clarified deliberate indifference and affirmed that correctional facilities can be held liable if prior knowledge of harm had existed. And next, we're going to be talking about Helen v. McKinney. And this was in 1993. The Supreme Court expanded on the Estelle decision, finding that the Eighth Amendment also protected against future harm to inmates, specifically the risk associated with long-term exposure to environmental tobacco smoke. So the next one is going to be a passage from the Americans with Disabilities Act of 1990. And the Americans with Disabilities Act represents the first comprehensive civil rights law for persons with qualified disabilities, defined as persons with a physical or mental impairment that substantially limits one or more major life activities, persons with a record or history of such an impairment, or persons perceived by others as having such an impairment. Under Title II of the ADA, no qualified individual with a disability shall be excluded from participation in or be denied the benefits of the services, programs, or activities of a public entity, And this was used in Pennsylvania Department of Corrections v. Yelensky. This is in 1998. The Supreme Court held that Title II covered persons in state correctional facilities, reasoning that incarcerated people with disabilities are included in the definition of qualified individuals, and correctional medical services are services of a public entity. So these are some examples of laws and court precedents that support the rights of incarcerated individuals. However, there was also one law in particular that was pointed out by this article, and I'm going to talk about it here. It's the Prison Litigation Reform Act. And the primary statutory barrier, being the Prison Litigation Reform Act, restricted a person's ability to seek legal recourse while incarcerated. Among others, three provisions of this law substantially limit access to the justice system. So first, we have the proof of physical injury criterion, which restricted potential claims for inadequate mental health care, despite the high prevalence of mental health problems among incarcerated people, and evidence that incarceration can harm mental health. Next, the requirement that administrative remedies be exhausted before civil action may be pursued effectively requires that incarcerated people, many of whom have mental illnesses and cognitive disabilities, and who are on average less educated than the general population, comprehend and comply with exacting and varying grievance policies, such as filing handwritten complaints within a limited time after an alleged incident. So the article says that the PLRA also imposes non-trivial monetary burdens, requiring incarcerated litigants to pay filing fees in full with no option for a fee waiver. And by capping recoverable attorney fees, the law effectively limits incarcerated people to pro bono legal representation, which is in short supply. And many incarcerated people resort to self-representation, but such cases have a very low success rate, being around 6% is what this article says. That really kind of just tells you that there is a huge barrier that these individuals have to representing themselves in a legal setting to get the care that they need in a medical setting. So if you want to learn a little bit more about these, I will, of course, link this article in the description of this episode, and you can check it out for yourself to learn a little bit more about each of them. But for now, we're going to be moving on. We will revisit this article when we talk about the solution at the very end. And the next article we're going to be talking about is a primer on carceral health for clinicians, healthcare delivery, regulatory oversight, legal and ethical considerations, and clinician responsibilities. And this was published in Science Direct. So this article discusses the issues that are prevalent in carceral or prison settings and how clinicians can best treat patients that are living in these kinds of situations. To start, we're going to be talking about Estelle v. Gamble. So Estelle v. Gamble, as I had mentioned before, constitutionally protected the right to healthcare and was established for incarcerated populations. However, this ruling by the Supreme Court did not specify how healthcare systems should be structured. Therefore, there are differences in the policies based upon the jurisdiction and agency overlooking the prison, be it federal, state, county, or municipality. These can vary greatly. And there's also a difference between a public and private prison as well that we have to consider. Moreover, healthcare coverage looks different for people in prison. And since it might be challenging to discuss the insurance options for all incarcerated people because there are so many differences based on the jurisdiction and whether it's public or private, I can talk specifically about the policies put in place in California prisons. And that might be similar to what it looks like in other states, but I'll just talk about what I know about that. So the healthcare system that is used in California prisons is called the California Correctional Health Care Services, CCHCS. And CCHCS covers the full cost of medical services for incarcerated people, and they don't incur any fees for receiving treatment. So California does provide some support to the incarcerated populations in their prisons. However, in other states, their system may look very different to CCHCS. Some I know charge a copay or have a fee-for-service model. And these kinds of models require a payment that requires people to make money. And I found huge differences in the kinds of pay that are given to people in prison. Some as low as 41 cents an hour, some as high as $60,000 a year. This is kind of where the disclaimer comes in handy. There are so many differences in the kinds of prison systems that are out there, whether they are a federal, state, county, or city prison. It makes it very difficult to say whether the copay or fee for service model is a reasonable model to go with. But if you were making 41 cents an hour, it would be really hard to pay a copay that's $20. So I I want to err here with a little bit of caution in saying that all prisons that have a copay or fee for service model are restricting someone's ability to receive healthcare. In some prisons, this may be an issue. The healthcare infrastructure in prisons also may be relatively ill equipped to handle the size of their patient population. Many people in prisons have either emergency issues, mental health problems, and there is a higher incidence of chronic conditions in incarcerated populations. Therefore, there's a really high demand for medical care. And if this treatment is in high demand, inmates may be transported off site to receive medical attention at a community-based facility. And despite their reliance on these community-based facilities, many physicians typically don't have any formal training in carceral health. And that can be a huge issue for people that are coming to community health facilities receiving care. So the next thing we're going to be talking about is a special report that was put out. It's titled Indicators of Mental Health Problems, reported by prisoners and jail inmates. This is a study that's done between the years of 2011 and 2012. So reports state that 1 in 7 people in state and federal prisons and 1 in 4 people in jail met the threshold for serious psychological distress, which is an indicator of underlying mental health disorders. While we can say that this number is factual, there may also be an issue with collecting information about people with psychological distress in an incarcerated setting because you are in a very stressful environment. So, time spent in the setting may be a huge factor that can affect the incidence of psychological distress. And there was another article that I wanted to look at. It was called The COVID-19 Cases and Deaths in Federal and State Prisons. And this here states that during the COVID-19 pandemic, incarcerated individuals were 5.5 times more likely to get infected by the COVID-19 virus and 1.3 times more likely to die of COVID. While these numbers may not seem too substantial right now, we also have to consider that the population in prison is generally lower than the general population. Therefore, the researchers after this created an algorithm to calculate the adjusted death rate if the age and sex distributions of the populations were equal. And the result was that prison populations were approximately 3 times more likely to die from COVID-19 than the general population. And this data was collected from the UCLA Law COVID Behind Bars program, which was started in March of 2020. And it was launched to track the incidence and deaths due to COVID-19 among incarcerated populations. I'm going to have all these links down in the description of this episode if you want to learn more about any of these topics. So, like I said, we're going to go back and address one of the article's solutions to these issues. And that was the article out of the New England Journal of Medicine titled Healthcare in U.S. Correctional Facilities, a Limited and Threatened Constitutional Right. Here, they state that to address the issue of poorly structured healthcare systems to support the incarcerated population, accreditation agencies such as National Commission on Correctional Healthcare and the American Correctional Association have attempted to use a process similar to that of a joint commission, which accredits most hospitals serving the general population. So, while these programs may protect against legal challenges to the quality of care, they are not required, and there is no financial incentive for accreditation. Moreover, it's a very costly process, and the lack of incentive delays and deters many prisons from pursuing this kind of accreditation. And another current legal barrier that prevents incarcerated populations from advocating for themselves will be the Prison Litigation Reform Act, as we mentioned before. And that raises several barriers to filing suits against injustices that are faced in the prison healthcare facility and system and in the prison healthcare infrastructure. And this article argues that we can address these issues with a two-pronged approach. And that's needed to ensure a robust standard of care for incarcerated populations. And they call for a repeal or amendment of the Prison Litigation Reform Act, which could provide affected persons with legal recourse so that injuries could be remedied. And proactive legislation could empower an agency to define uniform standards of care, provide incentives for compliance and penalties for noncompliance, and establish an independent, well-resourced federal oversight body that can conduct vigorous and unannounced audits. Having these solutions in place, they are a good place to start if we were to try to improve the healthcare infrastructure of our prison system. So these were some of the solutions that were posed by that article. There was also some solutions that were posed for the issue of not having enough training for healthcare professionals. And this article was the one that we also mentioned earlier, titled A Primer on Carceral Health for Clinicians, Care Delivery, Regulatory Oversight, Legal and Ethical Considerations, and Clinician Responsibilities. And this article argues that it is the responsibility of physicians to advocate for their patients, including people that are incarcerated. And healthcare professionals are uniquely positioned to ensure that the basic rights and dignity are not eroded when incarcerated people access healthcare in non-correctional settings. So, as with all patients, clinicians are obligated to provide patient-centered care. And this is something straight from the article. And I think that that's all rings very true for people that are in the healthcare field. So the first article down in the description of this episode is going to be the one we had mentioned earlier about the legislation and legal precedents that are in place protecting and preventing our incarcerated population from receiving healthcare. And if you are interested in learning about how you can improve the kind of care that you provide to incarcerated people, you can check out the second article in the description, and that can provide you some information that you may be able to apply in practice. And some of the other links down below that are going to talk about how the social determinants in prison may affect someone's health. Thank you very much for watching this episode. If you are interested in anything in particular that I brought up in this episode, go ahead and leave a comment in the description and tell me about what you'd like me to dive a little bit more into. Please leave a like, comment, and subscribe to this show if you are interested in learning more about research, medicine, and various different topics in the social health setting. So thank you very much for listening, and I hope you all have a great rest of your day.